Good afternoon. Welcome to the Meet the Trialists session. I think this session is for everybody who didn't make it into that room in the last session. And my name is Scott Solomon, and I'm going to be here to talk about the PARAGON heart failure trial. If you were waiting to hear another trial, this isn't that one. To my left here is Stuart Connolly from McMaster's, and he is our discussant. And I think, Stuart, you're going to kick us off, and we'll talk a little bit amongst ourselves and then ask for questions from the audience.
So why don't we start off with just a little bit of background. Can you just, in a short few minutes, just tell us about the unmet medical need and what this study was trying to address?
So heart failure with preserved ejection fraction probably accounts for about half of all patients with heart failure. So we're talking half of about 60 million people worldwide. There is a huge unmet need. We've had very effective therapies for heart failure with reduced ejection fraction, reduced meaning an ejection fraction of 40% or under. You heard about one more effective therapy in those patients just a few minutes ago, but this is really the best of evidence-based medicine. Unfortunately, for heart failure preserved ejection fraction, for heart failure with an EF of greater than 40%, we've had really nothing. And so it represents a very large, substantial clinical unmet need.
Right, and that nothing is not for lack of trying, is it? I mean, there's been quite a number of studies that have not really shown any benefit in HFpEF.
There have been a lot of studies in HFpEF, and I would probably say it's not that they've all been completely null, it's that none of them have failed to reach their primary endpoint, and some came close and some came very, very close. But we've tested angiotensin receptor blockers in the CHARM trial, in the iPreserve trial. We tested mineralocorticoid receptor blockers in the TopCat trial. And we've even tested an ACE inhibitor in the PEP-CHF trial. And all these probably have some benefit, but not enough to make their primary endpoints in those trials, Stuart.
So now give us a bit of background about the sacubitril/valsartan intervention and why you thought it was going to work in HFpEF.
So about 10 years ago, we began a program studying sacubitril/valsartan in heart failure, which of course resulted in the PARADIGM heart failure trial. In heart failure with reduced ejection fraction, we compared sacubitril/valsartan to enalapril in PARADIGM in 8,500 patients and showed a 20% reduction in cardiovascular death, heart failure hospitalization, improvement in all-cause mortality. And again, this was in comparison to what was considered at the time the gold standard in heart failure. And at the time that we designed PARADIGM, we also designed a pilot study in heart failure with preserved ejection fraction called Paramount. I presented the results of Paramount 7 years ago at this meeting, and in 300 patients, we were able to show reduction in NT-proBNP, improvement in New York Heart Association class, and an improvement in left atrial size in those patients. So based on that, we designed the PARAGON study to answer the question, could we reduce morbidity and mortality in patients with heart failure with preserved ejection fraction?
Great. So, well, I guess everyone's heard that the study just missed its primary outcome. That must have been a bit of a bad day when you saw that.
Well, I would have to say that the mature way of thinking about this is that the truth is never a bad day. But this was a study where, as Stuart is alluding to, we saw a 13% overall reduction in the primary endpoint, which was total first and recurrent heart failure hospitalizations and cardiovascular death. The upper confidence interval just crossed 1. Our p-value was 0.059. Just to give you a sense of how close that was, 7 events could have flipped that to the other side. So when you're talking about a trial of 4,800 patients, you have to realize that a few events that can change something, that is the definition of a borderline result.
Yeah, I mean, it's a modest treatment effect at best, a 13% reduction, but there was clearly some secondary outcomes that suggested that this was real, that it wasn't just a play of chance that got a p-value that wasn't significant. You want to share that with us?
So I agree with you. This was a modest treatment effect, again, against an active comparator, valsartan. But we had several secondary endpoints that were in favor of sacubitril/valsartan. So we looked at improvement in New York Heart Association class, and there were more patients whose New York Heart Association class at 8 months improved with sacubitril/valsartan and fewer patients who worsened, and that was highly statistically significant. Nominally, though, because we missed our primary endpoint, we had 1 point improvement in Kansas City cardiomyopathy questionnaire. But when we look at a responder analysis, the percentage of patients who improved greater than what we consider to be clinically meaningful, or 5 points, we see that more patients improved than worsened in the sacubitril/valsartan arm. We saw a 50% reduction in worsening renal function, which was defined as renal death, end-stage renal disease, or a 50% decline in estimated GFR.
And that was the one that really impressed me, because, I mean, heart failure class and questionnaires, I'm always a little less, it doesn't seem like quite as hard an outcome, but changes in renal function and such a large effect, I thought that was pretty impressive.
We saw the same thing in the PARADIGM heart failure trial, so we believe this really is one of the mechanisms of this drug. It almost certainly has benefit in the kidney. You're going to see a lot more of that in the next few meetings where we'll present more of those data as well. Importantly, and I think you were alluding to this, we saw that there was real heterogeneity here. Now, we've always known that HFpEF was a heterogeneous disease. We've realized that this is a phenotypically heterogeneous disease, but these data suggest that it may not just be phenotypically heterogeneous, it might be therapeutically heterogeneous as well. So what we saw was that of the 12 pre-specified subgroups, and you have to be very careful about subgroup interpretation, and we both know this as trialists, partly because you might end up with, for example, in one subgroup, more patients with a higher ejection fraction or more diabetics, and that might drive something else like a regional interaction that you're interested in. So what we did is we combined all of these subgroups, the interactions, the covariates in a multivariable model, and then you see what comes out of this. The only subgroups that remained statistically highly significant were ejection fraction and sex. So we saw a 27% reduction in the primary composite endpoint in women, and we saw a 22% reduction in patients with an ejection fraction at or below the median of 57%.
So, I mean, of the 2 subgroup interactions that you reported, one was sex and the other was left ventricular ejection fraction. I personally was impressed by the left ventricular ejection fraction one far more than the sex one. I mean, I think it's because this interaction has been seen before, and it also it is, I think, consistent with the fact that the intervention was effective in HFrEF. So by going down to a population of patients that's closer to the HFrEF population and then seeing an effect there suggests that just the cutoff of 40% is arbitrary for HFrEF. And it increases the biologic plausibility. Whereas for the sex interaction, I don't have like this biologic rationale that jumps to mind. Oh yes, of course, women are different because their physiology is X, and therefore they should respond to neprilysin inhibition. Am I missing something?
No, I agree with you. I think there's so much biologic plausibility in the ejection fraction finding. When we saw that, we weren't surprised. As you alluded to, we had seen that in 2 prior studies. the CHARM trial and the TOPCAT trial, where we saw a declining benefit, if you believe there was benefit in those studies, declining benefit as ejection fraction rose. And so what we're seeing here is really the same thing. This is a patient population, the lower EF group, that is adjacent to the population that we studied in PARADIGM. We all know as clinicians that ejection fraction is not binary. There is no difference between a patient with an ejection fraction of 39% and 41% because that's well within the margin of error. And so this is continuous. And when we look at this across quartiles, when we look at it continuously, we see the same thing, that the benefit is greatest in the patients with ejection fraction, I would say, that is below the normal range, let's say 55% or higher as normal. And those cutoffs may turn out to be different in men and women. For women, the sex interaction we saw, I believe it's real. I think there is some difference in the biology. One of them might be that women derive greater benefit at higher ejection fractions, and we hope to bring that data out at future meetings. But there also might be other things about the biology. I'm not sure I know what that is right now, but I can assure you that there will be a lot of interest in studying maybe some of the biological reasons why neprilysin inhibition might be different in men and women.
Yeah, it certainly needs further study.
Yes.
I mean, going back to ejection, by the way, I just want to say that I'm going to throw this open to questions. So if you're thinking you might want to ask a question, start getting it ready in your head, because we're going to turn to you guys for questions in just a couple of minutes. Do you think that, looking back then, that the definition of HFpEF versus HFrEF is very arbitrary, right? I mean, it was set at 40 or 45. I mean, you did it, but it was pretty arbitrary.
Well,
and looking back, I mean, perhaps the definition was just wrong.
If you remember, if you think back, I mean, originally this was called diastolic heart failure when we thought it was all about diastole. Then we did a trial about 15 years ago called the CHARM trial. And in CHARM, you could get in across the spectrum of ejection fraction, but if your ejection fraction was 40% or lower, you went into one of the two CHARM reduced trials. And if you were 40% or higher, you went into this other trial that we called CHARM preserved. We think that was the first use of that term, preserved. But preserved is different from normal. And clearly, normal begins at a much higher ejection fraction. These patients have systolic dysfunction in the range below, say, 55, 60%. They have evidence of systolic dysfunction. We know that from many, many studies that have shown it. And I think maybe our mistake was calling heart failure with reduced ejection fraction 40%. Maybe we should have gone up to 50 for that.
Or maybe there's more than one disease here too, right?
Or maybe
because
there's more than
severe
one.
Systolic dysfunction looks a lot different from someone who's got a stiff ventricle and an ejection fraction of 49%, I think.
I think this is going to make us rethink who are those patients with ejection fractions that are very high. You know, there's a growing appreciation that more and more patients with HFpEF might actually have cardiac amyloid. We need to figure that out because now there are potentially therapies for cardiac amyloid. So this is going to be an area of very intense research over the next few years, for sure.
All right, are there questions from the audience? Please get a mic and step up. I don't know where the mics are. Oh, there's one there. Is that the only mic? There's two mics, so if you want to ask a question, get behind the mic. Go ahead, please, sir.
Al Mohammed, UK. Thank you very much for holding our nerves to the peak and then dashing them down. The two questions I have. Do you think that we should stop thinking of a whole disease and now look at subgroups like you have alluded towards the end? And perhaps the second question is, should we say goodbye to HFmrEF, given what you have just said?
Okay, so first of all, I think we need to look at trials. When we look at trials, we need to look at the totality of the evidence, which I think is what Dr. Connolly did in his discussion. We have to be very cautious when looking at subgroups overall, but when there's really evidence and biologic plausibility for heterogeneity, I think we can go there. We are clinicians after all, and especially if there's an area of unmet need. So I think that we do need to think about looking at the phenotypes within our patient populations, and I think that's where you're going with the question. We didn't do that in PARAGON. We did try to get patients who we believe truly had heart failure. I think we did a very good job of that. But even within this group, there may be different etiologies, different types of disease, and it may very well be that unlike HFrEF, in HFpEF, the treatment, there may not be one size fits all. We may need to think about different potential treatments for different groups of patients. With respect to heart failure, mid-range ejection fraction, I take some of the blame for that because of some editorials I wrote several years ago. Maybe we should call it heart failure with mildly reduced ejection fraction, and I wouldn't make the cutoff 50%. I think we have to think about people who have evidence of systolic dysfunction, because the evidence from TOPCAT, from CHARM, and from PARAGON suggests that those patients might indeed benefit from drugs that we use to treat systolic dysfunction.
Can I ask another one?
Yeah, of course.
I apologize for half the audience before I ask the question, but I think, is it now high time that we give the ladies a trial for females in heart failure, since they are different?
That's a good question.
Okay, well,
be careful.
I will tell you that we are very proud of the fact that we enrolled more women in this trial than virtually any other trial in heart failure. 52%, 2,400 patients. And as you know, women comprise a much greater proportion of HFpEF than they do of HFrEF. In Paradigm, we only had about 20% women. Now, I've been trying to figure out the differences between men and women my entire life. I didn't know that it was going to happen on the stage at the ESC. But I think that we certainly need to be thinking about the biology of women. I'm not saying we should do trials just in women, but we should be paying attention enough and paying attention to the findings. Again, as I said before, this could be a chance finding. We're going to look for biologic plausibility, but we can't completely ignore it for sure.
Well, let's explore this sex interaction a bit more. So, did you see a sex interaction in Paradigm, for example?
In Paradigm, where there were 20% women, the benefit was absolutely the same in men and women. But what we see is that as ejection fraction goes up, the benefit wanes at a different rate.
Right.
And so we see that women seem to be deriving benefit with this particular therapy, and it may not be true of other therapies, to a much higher ejection fraction than men. Will be presenting those data.
But what that
shortly.
would perhaps suggest, and please tell me what you think, it would suggest that it has less to do with the neprilysin and more with the underlying disease that these women are. It may be a different phenotype that the women are presenting with. Because otherwise you would have thought there'd be an interaction related to neprilysin in HFrEF.
It may be. It may be. We saw something that was somewhat similar in the TOPCAT trial. I ignored it when I first saw this, but I think in retrospect, it might have been real.
Right. So it may be something fairly specific to HFpEF, again suggesting that this is probably not a single disease, maybe not even two diseases. It may have a whole spectrum of possible underlying etiology. Just like atrial fibrillation is not a disease, right? It's a manifestation of a whole variety of underlying heart pathologies.
That's a very good analogy. And there have been other therapies in which there have been sex interactions. For example, CRT is beneficial in women at a lower QRS duration than in men.
Interesting. Other questions, please go ahead.
Thank you very much. I have a question. Maybe it's the response will be the future. Are we using, coming back to the systolic dysfunction, maybe we are using the wrong parameter, the EF, as a cutoff to classify or stratify patient? Should we maybe use GLS, it's more robust parameter to define systolic dysfunction, rather than just 50% or 40% that are very, like, maybe grossier parameter, the GLS, the global strain, that it's maybe a more robust parameter to stratify patient and then use trial for heart failure treatments.
Yeah. We've been saying for many years that we need to move beyond ejection fraction. It's that single number that everyone wants to know about a patient, but it's only one dimension of what's happening with that patient. Global longitudinal strain, or GLS, actually is somewhat more robust than ejection fraction, but it's not in the mainstream as of yet. It's getting there because of interest, but I don't think it's ready for prime time, but you're absolutely right, it might be eventually.
So I see 2 questions, and we have 4 minutes. So let's keep the questions short and the answers short. I think you're next.
Scott, thanks for a great study and a very thoughtful presentation. How do I think about the findings with left atrial volume in Paramount, which were consistent over time in light of the PARAGON results? I usually view left atrial volume as sort of the integral of LV filling pressure over time.
So how do we think about the findings in Paramount that actually prompted us to continue and go and do the PARAGON findings? I think those findings were absolutely real, because we saw a benefit in terms of both NT-proBNP reduction and left atrial size suggestive of decongestion. And I would, if you're interested in the effects of this drug in heart failure, reduced ejection fraction, go tomorrow morning to the late breaker. You're going to see 2 other studies in heart failure, reduced ejection fraction. I think what we didn't expect from Paramount was the degree of heterogeneity. So we saw NT-proBNP reduction, I didn't show these data today, that was very similar to what we saw in Paramount. In PARAGON, we didn't have echocardiogram, so I can't tell you about the left atrium. But clearly, in some patients, this drug is having a biologic effect, without question. It just might not be everybody in whom we treated.
Thank you. Do you think that dapagliflozin is going to warn this story and to warn in next study this problem of heart failure with preserved ejection fraction?
So I'm not completely sure I heard everything in the question, but it's dapagliflozin, SGLT2 inhibitors in HFpEF. Well, the results that John McMurray showed today from the DAPA-HF trial that I was also part of are fascinating and fantastic, and we're very excited. A completely different mechanism of action, by the way, than the mechanism of sacubitril/valsartan, as he showed in that small subgroup of patients who were already on sacubitril/valsartan. There are ongoing trials with SGLT2 inhibitors and in HFpEF, and whether we see the same thing that we saw in PARAGON, which means that we see a similar decline in benefit as EF goes up, that will be very interesting, because that may end up telling us more about the disease than about the therapies. But stay tuned, it's going to be a couple of years before we see those results.
Thank you.
All right, we just have a couple of minutes left, so maybe I'll ask you
I have a last question, if that's okay.
really short.
Yeah, very short.
Because I want to ask one more question.
Hi, I'm Mahendra from Cairo. You already mentioned the possibility that a myeloid disease may have been something. We know the wild type is much commoner in men. Could we have been looking at hypertension as the main cause of HFpEF in women and other conditions, including amyloid in men? And maybe we've been looking at 2 different diseases.
Yeah, definitely possible. Very short answer, but I think it's certainly a possibility.
All right, so in the last 45 seconds, I mean, if you were going to predict who's the patient who you would choose to use this drug today, now in the HFpEF population, give us an idea of where you would cut it off, recognizing that it's not yet approved and that we have to go through a long process. But who do you think is going to benefit?
Well, I'm not a regulator. I'm not on the guidelines. I think we have to wait at least for regulatory approval, to be thinking along these lines. But as a clinician, I would say that based on what I've seen in these data, I wouldn't hesitate to treat a patient who is in the, as I said, heart failure, clearly has heart failure, who has an ejection fraction that is not in the frankly reduced range, but is below normal. And I would probably have different cutoffs for men and women based on the data I know.
Which you're going to share with us later.
Which I will share eventually.
Well, thank you very much, Scott. Beautiful study, and thank you.